Okay, good afternoon, everyone. It's about 4:05 on my clock, so we're going to make a start. We haven't got everyone here that's registered yet, so I'd imagine at some point over the next 5 or so minutes, we'll have a few late joiners, but that's fine. So thank you for joining. This is the fourth webinar in the series. Today we're talking about the E of the Safer Patient Flow Bundle. So we're going to be focusing on early discharge. I'm going to hand over in a minute to one of my colleagues, Erika, who is going to facilitate most of the session. We've got a few of our doctors on board. The general format will be Erika will give a bit of an overview about early discharge and some of the things that you can do and some things you can think about. We'll then have a big conversation chaired by Erika with our doctor. If there's anything that you particularly want to ask, or if you've got anything on your mind that you're thinking about, feel free to drop it in the chat box. We'll pick them all up. We'll spend the last 10 to 15 minutes or so opening up the conversation to anyone and everyone if there's anything that you want to talk about. And then we will close with just some final thoughts. The final thing that I would just say is we've got one more of these happening next Wednesday, same time, same link. If you've missed the other webinars in the series, they're all available on the ECIST network platform on NHS Futures. So I'm going to hand over to my colleague Erika now, who's going to take us through the rest of the session. Thanks, Erika.
Thanks very much, Spencer, and hi and welcome to everybody. I'm here to chair today's panel. My name is Erika McGinnes. I'm an improvement manager with ECIST, and I'm joined by 4 of our clinicians who are going to provide their expertise and their clinical views and experience in relation to discharge. So from left to right, Andrew Williams, who's one of our clinical directors and a community geriatrician. Bharath Lakkappa, who is a clinical associate and a geriatrician. Jyothi Nippani, another clinical director and also gynecologist, and Liz Deutsch, who is one of our clinical associates and also a nurse consultant. Today we are here, as we said, to talk about the E. In the context of the Safer Bundle, the E encourages us to consider at least a third of our discharges before midday. Nobody would dispute the importance of that, and those of you who were at the session last week will recall us talking quite a bit about criteria-led discharge. So we will come back to that in a little bit more detail today with the benefit of Jyothi and Liz's experience. And although the principle of safer is early discharge, we also wanted to reflect a little bit on the principle of timely discharge, both a little bit different, but equally both important in terms of supporting and facilitating hospital and organizational flow, which is why we are here today. So what is the problem that we are trying to solve? I'm sure you will all recognize this pattern of admission. It tends to peak around lunchtime and then again around dinner time. And if we overlay the discharges, you can immediately see that we have a problem rearing its head very early in the morning because we have insufficient capacity to meet the demand coming in through our doors. And those of us who are seasoned operational managers know and are sometimes assured that we will catch up by the end of the day. But of course, that's not the point, because catching up at the end of the day means that patients will flow into the organization late when staffing perhaps is reduced compared to our daytime shifts, but also those patients will have waited a significantly long period of time in the emergency department. And of course, everybody knows that that is not helpful for patients, but equally not for the staff as well. I'm going to start from the premise that we are all here to do the right thing, but I equally acknowledge, having just left an acute role not so long ago, that there are challenges that we need to accept and understand and develop processes and systems to work around. How many times have we walked onto a ward when the staffing position was exceptionally challenging? In that situation, clearly medications and cares for patients need to take priority. Competing demands are always going to be the case, especially on busy ward environments. And the fact that we perhaps haven't sometimes had enough time to agree our priorities just makes that environment a little bit harder. I think it's really important to acknowledge how complex the ward environment is, and added to that, the COVID challenges have only exacerbated that further. However, I think just as the picture in the middle of the slide suggests, we do have a chance to get our ducks in a row. And the three principles I'm going to kind of refer to are opportunities for us to consider how to do that. So we talked about discharge planning on admission a little bit last week. And again, organizing the patient and their family, but also processes around getting the patient ready plays such an important role. You've heard many of my colleagues talking about discharge in the context of hotel departures or getting ready for a wedding. And I guess that emphasizes the fact that in order to get ready for a specific point in time, it's really important for everything to be wrapped around that process so that everything follows the patient. You'll remember we talked about the questions last week that the patient needs to be in a position to answer when they are part of the ward round on a daily basis. Again, that information helps manage that patient's expectations. And the expected date of discharge here is really important in this context. And while I was doing my research for the slides for today, I read of an experiment that Gordon Caldwell, who's joined some of our sessions before, ran with one of his hospital wards, and it dealt with a scheduled on-time departure where patients were prepared that they would be leaving the ward the following day by, say, 9 o'clock in the morning. Now, you could argue that that may potentially introduce false delays into the process, but actually his research suggested otherwise. And not only did the board increase the number of patients that were able to be discharged before 12, but also the length of stay decreased because they were able to pull the new patients onto the ward early enough for them to be reviewed by the team before the ward round had ended. The afternoon huddle, I think, also offers us a really good opportunity to get organized and to identify what you remember we called golden patients last week. It gives us an opportunity to understand what we need to get ready, whether that be TCOs or booking transport for patients, just again to make sure that everything is set up for the patient ready to be discharged the following day. And it would be remiss of me not to mention our new discharge to assess pathways. I think within that, there is a cohort of patients, our pathway 0 patients, who may potentially lend themselves that little bit easily to allow us to facilitate an early discharge in the morning. I do accept, of course, that some wards have less of that group of patients. So how do we do this? And for me, the important thing here is to create a compelling narrative, and a narrative that our staff identify with. As an organization, if we simply say we need to facilitate 1/3 of our discharges by midday, that is unlikely to tug at anybody's heartstrings. But what if we made that discussion that little bit more relevant to the ward? And at ward level, breaking that conversation down potentially means no more than 2 to 3 discharges per day that the ward would need to facilitate before 12. So immediately you can see that the subject is getting smaller, but also easier for staff to identify with. The other thing I would absolutely encourage is for us to understand our constraints. And if you had to go back to your wards over the next few days, ask staff what they find challenging and what they tend to have to chase time and time again. And I would suggest that those are the elements that we need to incorporate into our tests of change and into our PDSA cycles to try to make the pathway and the process that little bit better. And of course, it goes without saying, we need to celebrate our successes, however small. That incremental progress, I think, will over time make a really big difference. So with all that said, and if we've achieved our desired improvements, what we then see is that discharge curve shifting ever so slightly to the left, and you can immediately see the benefits. So those discharges facilitated 2 to 3 hours earlier means that we are likely to have capacity on our acute assessment units to pull patients into our ward environments that little bit earlier. And we will be pulling them in during the day. So that means that patients are likely to get reviewed, as we said. They'll be waiting less in the emergency department. And all round, I think we have a system that is flowing more optimally, notwithstanding, as I said, that I accept that we are working in a very challenging environment. I'm going to hand over to Jyothi just very briefly. She has some experience on criteria-led discharge that she would like to share with us, which again, we will pick up when we invite the rest of the panel into the discussion. Josie, shall we bring you in?
Thank you, Erika. Yeah, so what it is in one of our wards is just an example of, um, clinical engagement of the team. So we have you got previous slide or the last slide? Let's look at the last slide first. Keep moving. Yeah, this one. So this team were asked to do what the safer bundle said earlier on. So the carrot for them was if they discharged a patient early in the day, then they could pull one of those their patient from acute medicine. So they could choose which patient needed to go into their ward. So that was the carrot for them. So they were doing earlier discharges in the day, going into acute medicine, pulling the patients they want. So by giving this active pull and the power to pull the right patients into the ward, they already started showing that getting the right patients the right ward, the length of stay started dropping on that ward. Now, if you go back to the next slide, the previous slides, um, what came about as criteria-led discharge just to facilitate weekend discharges. The nurses on the ward said, look, over the weekend, I know whom to discharge, but we're having to wait for the weekend team to come and discharge this patient. So why can't you tell us exactly what you want and we will do what you want? So that was what started off criteria-led discharge. And once they started having that culture of making it very clear what exactly do you need to be in place for this patient to go, it worked better during the week than the weekend actually. So these slides are just to show. The previous slide shows that the weekend discharges did go up, but the weekday discharges actually increased even more because the same culture which they were using over the weekend, they were using during the week as well. So morning they would have the ward on and say, now can I discharge this patient by evening if everything is okay? And yeah, that's fine. The nurse would say, I mean, I'm happy to do so. And then they would not get it checked by anybody. They would do it. So those two slides are just to show that what actually started off as a weekend discharge project actually helped getting weekday discharges much earlier. The same thing applied to the night nurses. The night nurses then said, why can't we discharge first thing in the morning and get them ready so you don't have to do the ward round first thing in the morning in these patients. So that led to the early morning discharges as well. So the last slide now. You can skip that if you want. These are the lessons we learned. We started off with culture change about stickers for the weekend, but then as I said, once the culture changes, it had a much more profound effect on the weekday discharges. And then it was no longer about just the weekday discharges, but earlier in the day discharges. So it's basically about the timeliness of the discharges that actually it worked on. So just an example to show that it's all about the culture, empowering everyone to and being clear on exactly what you want so that and everyone can actually act on what the criteria and discharge without having to have the senior review once again. Thank you.
Thanks very much for that, Josie. And I think it emphasizes, and we will talk about this a little bit further on in the session when we bring Liz in, that criteria-led discharge is a way of life. It's not just a weekend kind of approach to improving discharges. Clearly, if implemented properly, it will absolutely do that. But embedding it and embracing it and making it part and parcel of the daily ward process, I think, is where it makes a difference. So we wanted to now bring our audience in a little bit, and we wondered whether you would join us in a very short Menti session. There's only 2 questions. Those of you who haven't used Menti before, if you scan the QR code by using your camera on the phone, or alternatively, you can go to menti.com and input the code, which is 43276999. I'll just give you a couple of minutes to do that. I can only see 2 people so far, so I can see 13 on the call, so we'll give you some more time. Okay, seems like we're thick. So we'll start with the first question. And the first question really is to get your thoughts, because we'll build on this when we invite our panel in to provide some further perspective and their own kind of clinical experience. So what barriers have you faced when trying to discharge patients earlier? Okay, we've got job planning. That's interesting. Permission seeking, not seen as a priority. Okay. There's always room for a clunky IT system in every hospital. So nursing staffing and kind of challenges coming into the conversation again. Meds and TTOs, and not surprisingly. I'll just allow a few more seconds for colleagues. Okay, we have some concern about criteria-led discharge, which I'm sure we will be able to allay in the best possible way through our panel's expertise. Criteria clarity. Thank you. And now we're flipping the conversation ever so slightly to a more positive angle. So what would support you to discharge patients earlier? So if you had to think about those conversations you would want to have with your teams or with your kind of management colleagues, what would you ask for? Effective date of discharge. Yeah, we talked about how important that is. Yeah. So there's a theme running through here about planning and kind of being organized that little bit earlier. Okay, yeah. Something about engagement, which we will come back to again. Patient involvement, absolutely. Yeah, challenges with staff and continuity, undoubtedly that would always kind of play a role. I guess it kind of reinforces for me that importance of that kind of PM huddle again. Families. Fantastic. Thanks very much, everybody. We will build on your feedback with our panel, and now's the time for me to bring them in. And we'll start with Josie because she's the first person on my screen, but we'll bring Andrew, Bharath, and Liv into the conversation as well. So Josie, reflecting on the challenges that colleagues have shared with us today, what's your experience working in your local trust, and how have you dealt with challenges around discharge, to whether that be to make it more timely or to bring patients up for discharge earlier in the day?
So yeah, as I mentioned, this was the carrot that we used, and this is already there in the SAFER bundle, that if you have your golden patient and you can discharge that patient before 10, then you can choose the one that you want to bring in. So that was a big carrot for people to pull their right specialty patients into their wards. So they were very keen to discharge those patients earlier on. So that was what started on the journey of, earlier discharge. And then you think, if you can do, why can't you do 2? And why can't you do 3? So what is it that made this 1 possible? So then better planning, then you think, okay, how do we get the phlebotomy earlier on? How do we get the TTOs written up the day before? So it's all about planning, really. So that is how the culture of earlier discharges, worked. And also the junior doctors on our ward, they felt that they were ending up spending a lot of time after 5 writing up TTOs. Now, the earlier the discharges were happening, and there's a complete shift of the work from evening to morning. So they would peel off the ward rounds and do off the discharge early, so that the patients are ready as and when the decision was made to go. So these things started the left, the shift to the morning, the whole process, which was staggering on to the evening, was shifting to the morning. So these were the early things that we adopted to get patients moving earlier on.
Thanks, Jyothi. Bharath, shall we bring you in? I know you've been doing some very recent tests of change in your organisation. So is there anything we can share with colleagues around the work that you guys and your colleagues are doing around discharge?
The thing everybody needs to agree on first thing is everybody's stressed, and that's completely, you can't just do big change. We did small steps. We agreed on small steps. One of the things I could expand on what Jyothi said was the ownership of the follow-up of tests was taken by one of the registrars or somebody else. And then what we said that, why do we need to repeat it? And suddenly we saw 50 to 60% reduction in follow-up tests. And then again, if the patient's not going to have follow-up tests, that should be kind of a tick box for you to start an electronic discharge summary early, and then it can be followed up, and then it can be signed off earlier on in the day. And even though you don't, that led to the criteria led because of the ownership that there's no blood test being done today, and those are the things which leads to criteria led discharge. The other interesting thing which everybody got ownership was, it was not just the therapists who are going to mobilize the patient. On ward rounds, as part of it, the junior doctors will be mobilizing, and around about less than 20% will need some extra support. So it was small early steps which were put into place, and then it will fall into place. But I think those steps need to be done before we can get them to see the early discharges. The other interesting thing, which the juniors were the ones who pointed out to us, was transport's really important. But when they had a conversation with the patients, nearly 80% of them had family members who could pick them up. And those are the family members who've been taking them around to coffee and tea on a Saturday and Sunday. And suddenly we didn't need to wait for transport to come. And that was one of the biggest things we learned, was just by one of the juniors picking it up and talking to family members saying, can you pick them up tomorrow at 12? And so I think every small step counts. And in the bargain, you will get the kind of credit of pulling the patients which are appropriate for your wards, which is mainly frailty for our cases, complex frailty patients, delirium patients, which we will pull through. And then also that'll be easier for us to manage because that's what we do. Hopefully a few small steps first, and
Absolutely.
then it'll all add up.
Absolutely. And I guess you emphasized the point that this is also about incremental progress, and that kind of small gains will make a difference. Andrew, you put a post that I'd like to kind of pick up on. So you said giving permission to do discharge tasks right away is so important. How would you sell that to other clinicians? And I ask from experience as a manager, having found that quite a challenge to kind of sell as a principle and a concept. Andrew, I think you're on mute. Sorry.
I think it's really hard, and I think what lots of consultants do, and I hold my hand up, I'm sure I do it at times, is we say one thing and behave another way, and we say, oh, discharge is really important, but then we tut and huff when the ward round doesn't go smoothly because the juniors are doing the tasks we want them to do for the discharge. And I think so much does come down to that leadership about, we do need to be saying those early discharges and those tasks are really important, rather than we give lip service to it, but actually what we want is a nice lot of people follow me around, so I feel very important. So I think it is that consultant engagement to lead that whole team. The juniors take so much from their consultants, so that, as Jyothi said, that moving evening work to the morning and doing the TTOs right away and those things, we need to model that behaviour as consultants, and we need to get clinical engagement to say this is really important and you need to be doing it, and saying to the juniors, do you want to just stop and do those TTOs now, not just giving them permission to, but actually suggesting it. So I think that leadership of it's a whole team issue, and apart from the really sick patient on the ward, the number one priority is sorting out tasks and how we get those done. And without that, and that being really modelled, I think it's really hard to make good progress. The other thing I'd say when it comes to that engagement bit is, I think there's a first bit about understanding what the issues are, and they're always slightly different ward to ward, and there's nothing better than getting lack of engagement than walking onto a ward and saying, oh, your early discharge is rubbish, I know what your problem is, this is what you need to do. And I think that those first little bits of questions to try and understand the process builds an awful lot of trust that we are listening to you and working with you to get that clinical engagement. So I think there's a little bit about seek first to understand, albeit the patterns are obvious and happen in lots of different places, but we need to to do that engagement piece and listen to people and understand their issues first. They'd be my two bits.
You touched on two very important points, and you're right. I think understanding constraints comes at a ward level conversation rather than generic. There will be, as you say, common themes. I'm sure TTOs and kind of medication will be touched on transport, but also I think our assumption sometimes that patients need transport when perhaps they don't. But the principle of leading by example, and I would stretch that further, it's not just for clinicians, but I guess for all of us as leaders to do that and to encourage others to follow suit. Liz, have we got you with us on the call?
Hello, I'm on the call. Yes, hiding in the background.
Hi.
Hello.
So we've reflected very early on in the conversation about how popular the subject of criteria-led discharge is becoming, and absolutely accept that it's not just a weekend kind of discharge solution. But what experiences can we share with colleagues around criteria-led discharge? Because there is, I think, some real potential if embedded properly for it to make a real difference to our ward processes day to day.
Yeah, thank you for that. I think some of the things that have already been mentioned, I just want to recap on. A very important point that was made was small things that lead to it. I think when I've spoken before now about people who are frustrated because they've started and then they've had to stop, they lose all of that investment and the knowledge and the energy that they put into it because they've had to stop because they perceive it didn't work. So I think it is about anyone on the call appreciating that it is a lot of smaller things to do, because I'm a bit of a baker in my spare time, and I always say to people that if you put a terrible icing on a really good icing on a terrible cake, it's still a really terrible cake. And the moral of that story is that if the discharge process has still got glitches in it and issues, it's pretty much no good going down the criteria-led discharge route straight away. So I go back to the two speakers who've already clearly said it's small things that lead, and then criteria-led discharge or clinical criteria-led discharge will start to fall into place. But in making a couple of additional points to that, I made a few notes before I came on the call. And so they're notes from the heart and the head rather than a textbook. And they are very much things that I've done today. And it's to make the point that patients are selected for clinical criteria for discharge. They're selected. So you may have 25 patients on your ward and only 6 are at that point in time suitable. So it's about, if you look up the word criteria anywhere, it's about selection of how you select or deselect. So for me, the very big take-home message would be taking the early opportunities. So if you're in a surgical area, it's looking at patients as they arrive. If you're where I am, it may not be quite where they arrive in medicine. It might be on handover, nursing handover, therapy handover. And then you move on to the next possibility for selection is on a ward round, but it's certainly not confined to a traditional ward round. So I think it's summarising that point, it's early selection. And there's no such thing as getting it wrong. If you select a patient on handover and you're mooting the discussion and you think the patient's suitable and you're a nurse or you're a therapist, and then all you can do is take that forward to the ward round, but you need to be on it. And if they say absolutely not suitable because you didn't get it wrong, you just aired the thought that you might get it right, if you like, and the patient might be suitable. So I think to start the conversation, to take the opportunity early at any of those points in the patient's pathway, on arrival, when you're doing your handovers, when you're doing a ward round. It's much more than just having a really good standard operating procedure or protocols, clinical protocols or clinical pathways, because I'm a great believer that anybody can follow those. I think it's the clinical decision making around those that are more difficult. And I'll just draw breath there for any comments.
I guess the one thing I would want to kind of come back to, having also seen it on the mental feedback, is kind of anxiety or reluctance to engage with criteria-led discharge. And you made the really important point that introducing criteria-led discharge in the wrong environment isn't going to be the magic bullet that people kind of might be expecting. So if you had to offer any advice to colleagues in terms of how to sell criteria-led discharge, or more importantly, how to prepare the environment ready to be receptive to criteria-led discharge, what would they be able to share in that respect?
Thank you. So preparing the environment for me would be being clear who's on your team. I mean, you don't always get the choice, but the environment comes with a team or with several teams, and that team actually know you're intending to go about doing it, that they understand what it is. The biggest thing I found is not that people aren't receptive per se, they don't want to know. They do. They don't always understand what it is you're trying to do across the different teams. And we're in complex environments now where we've got different teams coming in. So where I work, we have older persons liaison team coming in, Opal. We've got intravenous therapy teams coming in. We've got psychiatry. It really is complex. I think across those teams, there isn't. It's not a criticism. Absolute fact. There isn't always the parity of understanding about what we're really talking about. So to prepare the environment is not an environment. It's where the patients come from and where they're going to. And I always describe myself as working in a sandwich. The patients that come to me are going to leave. They're either going to go home rather quickly from a medicine unit, or they're going to move to another ward where they're going to receive their ongoing care. If the environment they go to, no matter how good you are, doesn't operate any kind of clinical criteria for discharge, it's no good you identifying if there's no one on the onward team to deal with it. So in preparation of the people, preparation of the process. So what can you get in place early, such as one of the big things we did was work with the pharmacists, because this lovely thing called tablets to take home was always the biggest barrier. You know, how many prescribers have you got? How many non-medical prescribers have you got in that environment? How can the process of repatriating medicines be dealt with more quickly, especially if you're not keeping people in very long? Those are small things in the process I mentioned, let alone the transport and everything like that. But I think the biggest barrier we come across is the prescribing, and that slows things down so that people lose heart. They say, well, I'm doing clinical criteria for discharge. We've got them in place. We've got a broad proportion of people bought into it, including our consultants. And they normally get bashed as, oh, it's the doctors that don't want it. It's absolutely untrue. What happens with us is the same barrier comes up. So the theory of the process is restrained by the speed of the slowest step, which is TOC. And so if the speed of the slowest step is just as slow with criteria-led discharge, people lose hope. So that's got to be prepared, looking at the medicines, looking at your prescribers, looking at your team. I'll draw breath there.
Thanks, Les. I have one final question, because I know it's come up in conversations that we've both had with people. So if colleagues were to implement criteria-led discharge, how or what would we encourage them to measure in order for them to be confident that what they are doing is going the right way?
Yeah. Thank you for that as well. That question has come up more and more and more recently, and they people who ask me refer to it as a metrics. So I usually bounce it back and say, is it on your metrics? What's on your metrics for patient discharge? Not what's on your hospital metrics that nurses do or doctors do. What is it actually a feature anywhere that's fed up to the board or to the divisional heads, however your hospital is structurally organised? Is it a feature? Is patient discharge a feature? And if it is, which bits have you got already? And if you've made a decision of a time to measure for discharge, and I'm not going to be suggesting times here, lunchtime always seems to be suggested, but for us it would be no good because the bulk of ours come in at lunchtime. So my environment says a measure would be, have you improved the speed of the process? So from when the decision to discharge was made, and it goes back to some things that Andrew has said as well, when the decision has been made, how long is the process before the patient goes? And if on my area I can speed that up by half an hour or an hour, sometimes I'm really lucky even more, through the introduction of clinical criteria and the empowerment of staff, then that to me is a good measure for me in my area. So I go back to ladies' tights. One size really doesn't fit all. And I do believe that you have to look at what it is you're trying to improve that's a peculiarity in your area. There are some big things we're all trying to improve. But for me, it's that discharge process time. It grinds to a halt on some things. I'm going to just throw a little caveat in, if I may, and that is that sometimes I am known to slow the process down. No one ever talks about that. The reason why I mention it is because when patients are being clinically optimised and we don't move them, We don't rush them out. We don't move them to a lounge, or we don't move them to an ongoing ward because we believe we can deal with what needs to be done and they can go. There are occasions when bed managers have said to me, but, you know, by introducing criteria-led discharge in some areas, if you're taking ownership and not moving the patient, maybe you should be measuring less moves. Maybe that would be your measure. So one of my measures is certainly less patients move just for a few hours, because that's a whole load of work for porters, for nurses to readmit patients, for doctors to familiarise themselves. So is a good measure that the patient was moved less? Is it that the process time was improved?
Liz, thank you very much for that. There's lots of food for thought for colleagues to consider, but you touched on a really important point, which is that tension of kind of the perception that we might be slowing the process down or delaying. So I'll bring the panel in and I'll ask Andrew first. How would we, or what kind of would we kind of offer to deal with that tension that actually discharging early doesn't influence the process negatively in that context? And clearly what we're saying here is not to keep the patient to the following day to influence the statistics. So going back to what Jyothi said, it's more about kind of merging then timely discharge into kind of early discharge. But how would we deal with kind of people who might be anxious about that?
I think it's really interesting, and I used to, pre-reading the stuff from Gordon Caldwell, I used to say, oh, I don't discharge any of my patients early in the day because I'm discharging late the day before and I could keep them all in an extra day and make my figures look good, but I'm being the hero and getting them out really, really quickly. And I'm not sure I was right. And I think there is a bit about, do we use that as an excuse? Is that really a reason, or is that an excuse? And should we be really making these discharges happen early? And as a geriatrician, most of my discharges are planned. I don't have that many that go out on pathway 0. Those that do, I think, are different. But actually, if we're planning discharges, should we be getting them out in a really planned, controlled way rather than rushing them out the door? I don't know what the answer is, but I was really impressed with that work from Gordon, and it has changed my thinking. If that's the answer to your question, but I think it's a really difficult one to know whether we're really doing the right thing or we think we're doing the right thing at times.
It certainly was, and I was, I guess, just as kind of surprised by the data for the very reasons that you reflect on. So I guess if we kind of take the kind of topic of engagement a little bit broader, so what have you all done on your local kind of ward environment or clinically to engage your team? So we talked very much about the importance of this being kind of bottom up and for everybody to understand the roles and responsibility. For us in the work that you're doing with your teams at the minute, what approaches or what steps have you taken to kind of enforce the principles of staff engagement in the work that you're leading on right now?
I mean, the thing about Liz and Andrew touched on the criteria-led discharge. We have taken a little bit more focus on the individual aspects as well. So if the junior most person is asked to review the bloods, they usually repeat it. So we ask them, well, why do they need it? And do they need it for follow-up? The second aspect, what we have done is when they want a specialty review, we will ask them to run it by a senior just to make sure that does that going to hold up discharge delay, or does it going to make any change for the management plan? The third aspect is the biggest concern we found from patients and the juniors when they spoke to family members was family concerns about something going on. When we asked them to break it down, they were talking about concerns which have been existing for a long time. But when you ask the patient, that wasn't the concern for them. Their concern was more about, I think one of the medical students did know that the main concern for them we found was 30% were, can they not stop taking medication, reduce medication? So it is, every team member thinks of it differently. So for us to get the patient home early, I think all of them need to be playing a part in it, but also having, as Andrew said before, the senior most person, the consultant needs to show the way. That means we do get patients who go home and they will fall. That is not related to the reason that they discharge themselves early. The studies actually clearly says if you admit somebody to hospital and they discharge, that increases the risk of falls as well. So those are the things we need to explain to the juniors and to the MDT staff, that things will happen, but not related to early discharge or criteria-led discharge or some things like that, and taking them on board to ensure that if something happens, we show them what was right and what could have been corrected next time. And then empowering them to do it is more important than trying to just say, we need to send them home early.
Perfect, thank you. And I guess it emphasizes the fact that everybody in that process has a voice which is equal to other people. Jyothi, can we bring you in on the same subject matter? I know you've done quite a lot of work recently on discharge. So how have you spread that infectious nature of yours across the ward and encouraged everybody else to be just as enthusiastic about it?
So I'm a bit of a toughie. I'm just talking personally myself. No one gets a bed on my ward unless they have agreed with me that they deserve a bed to start with. So similarly, they can discharge anybody, but if they're keeping anyone, they need to run it past me as to why they're keeping them in. That's simple. They have to explain it. And I'm available. That's the other thing. I'm available. So they don't have to worry, oh my God, she's not here. So I'll just wait for her. No, they've got my phone number. They can call me anytime, but there's no excuse to keep anyone. Once we've agreed the patient is going, that was what I found most irritating, because you would say, expect the patient to go, and then someone has changed the plan overnight. By the time you come in the morning, the patient is still there. And he says, why? Oh, but the temperature went up or something like that. And I said, no, why didn't you ask me if it was okay or not? I would have said something. So these are the little things which started the process of, you ask me, I'm available. And then if there is the number of jobs at the end of a ward round, take the difficult ones, be part of the team to take some of the actions yourself. It's not just leaving all the actions to the team. So you're part of the of the team who takes some of the actions. And I always pick up the most difficult ones. Then I'll say, this is the most difficult, I think, for you guys to deal with. I will deal with that. Are you okay with the rest of the? So checking with them, they're okay, that they are happy to take on the tasks that they have to do. Then also come back and make sure that all the team members are leaving the ward together. So you don't dump it on a few people and let them to carry on with the rest of the work. So everyone is going home together. So you share the work that's left and then you all leave together. So that gives you a team culture. So you feel that you're part of a team. And then this is what I have done on my wards. There now needs to be a very clear explanation if somebody has changed the management plan, and I'm available to discuss. And that is so that both of them are there.
Perfect. That Andrew's added to that conversation and has suggested that there's a kind of a perception that it's only the kind of consultant that can decide on a discharge. So it emphasizes, I guess, the points that you've all been making about how important it is to spread that leadership as widely as possible, while at the same time kind of leading by example. Andrew?
Yeah, no, I think it just kind of came back on that point. I think it feels like there's a view that for a patient safety point of view, and I'm not saying we shouldn't be safe, anybody can say, I've got a concern about this discharge, let's stop it, let's postpone it, and that's okay, and we need then to remake a plan. I think we need to change our reaction to that about, that's fine, what would we need to do to reduce your anxiety or concerns about this discharge or to make it safe? Not if we've got a concern, the automatic response is we cancel the discharge. It's kind of like, what's the safety net to make that safe and feel comfortable about it, both with families and with patients and with other members of staff, rather than, as Jyothi said, she's made all these great plans, left the ward, and everyone goes around and cancels her discharges without telling her. I think it's just that culture change. We don't want to be unsafe, but there's this presumption that if in doubt, we keep people in, rather than what can we do to feel it is safe or to make it safe.
Perfect, thank you. And I think that really emphasizes the point. My final question for you all is about our new discharge policy and our discharge to assess pathways. So discharge has always occupied centre stage in our lives, and I don't think that's likely to change anytime soon, particularly as we head into the winter. Andrew and Joyce in particular, but we'll bring everybody in because I know you've all done kind of work related to this. How helpful do you think the new discharge to assess pathways could be in helping focus teams' minds on kind of discharge in general, but then perhaps also early discharge? Andrew, shall we start with you?
I think it is. I think if I'm being really honest, the implementation of discharge to assess has been quite variable around the country, and there's some systems that are doing it really, really well, where those discharges do happen in a timely way. There are some others that I think are really struggling with its implementation, where I'm not sure it's quite landed and has made the improvements we'd hope it should do. I think one of the things it does do, and I think the discharge pathways and the the kind of guideline percentages does make us realise how many discharges are under our direct control, and particularly those pathway zero discharges. Well, there's no reason why those can't happen right away. We don't need to think about the really complex discharge, pathway 3 discharge, or somebody who's waiting on a package of care and when will it start. Let's focus on the bits within our control and make those discharges happen. And it's the frequent, less complex discharges that make the flow happen, rather than the small number of really complex discharges that can get delayed that we need to focus on. So I think that focus on what's in our gift to fix, rather than that externalizing it, and if only our community partners, local authorities, care agencies, whatever, did things differently. Well, hang on, what's in our gift to control, and how can we make that better and slicker?
I know you're on mute, Erika, but that's fine.
You go ahead, Josie.
That's okay. So I would say, I mean, I went on a site visit this week, and oh my God, I was really despair. I was in despair. People even don't know that the policy exists, and I'm really shocked. It's now 18 months. So, and especially our frontline clinical staff, they actually don't know that. So they don't know the policy. My first thing would be, please download it. Please read it. It is really valuable. It is actually there to help you to get patients out safely, not just throw them out. You actually can do a safe discharge. It talks about medical optimization and a quick ownership by your community teams. But then unless you actually say the patient is medically optimized, there's no chance for the community to pick them up. So it is really our responsibility, and it was really fantastic to have Bharath with me on that thing, because he came and said, look, I can take that patient, come on, send them to me. And it was an education for the acute staff. They didn't know that the community staff can do so much once they're discharged. So it was really good to have that community coming in and talking to the acute and saying, come on, we can take them from this point on. You don't need to make them fully fit. So I think there's a great value. I won't waste more time, but please read it, and it is definitely useful.
More work to do, Jyothi, by the sounds of that. We've got 8 minutes, but I'd like to invite Liz and Bharath back in just with any final reflections before we hand over to Spencer. Liz, any reflections from you about discharge to assess and its role?
Thank you. So working as I do within acute medicine, we see an awful lot of obviously the pathway zero patients. And I think people fully understand that. I think where a reflection would be that where the pathways get more complex, the understanding of the types of patients that might fit those pathways, certainly in the acute area, is probably less well known than it should be. So I'm a great believer in giving examples wherever possible. So we have been doing something very strange without any names or that, but we've been laminating cases on cards and putting them into the office of, these are the kinds of cases, this is a successful case. So giving examples of success rather than people being pushed back if they are not quite finding the right routes within those pathways, because it's a whole new language.
Absolutely, and I guess people need time to kind of, get that new process kind of straight in their heads, never mind operationalized in certain cases. Bharath, what about your reflections? I know as a geriatrician, you're less likely to see many pathway zero patients, but kind of broadly speaking as well.
The thing which really reflects to me was the understanding of the pathway 0, 1, and 2, and 3 really helps the people who want to get things done. So if they don't know there's pathway 1, these are the processes they need to do, or these are the community teams which can support them, and there's quite a few pathways. Most of the places have invested a lot. I don't think they know about it. They might be new to the place. As you know, nearly 20 to 30% of the staff are new in each place. If you go around to different teams, they do not know any about the local kind of infrastructure which is being put in. There's lots of things happening. The minute they find out about it, and we're finding weird and wonderful ways for patients to get home, because the staff on the ward, therapists, nurses, even the discharge coordinator, HCAs, they are aware of how this patient can be going home. The classic example was a HCA picked up the phone and said, my mom is waiting for transport. And it was like, hold on, can you take them home? That was it. And it's immediately, they know that they learn from one and then they spread the news. So just understanding of the pathways will lead to people coming up with small improvements and also really bright ideas locally, which is suitable for each of the wards or each of the places they are in. Yeah.
A huge thank you to all of you for contributing to such a rich discussion today. Thank you very much. I hope that everybody on the call has found the discussion useful and that we've offered you some food for thought. So with 5 minutes to spare, I will hand over to Spencer. Thank you.
Thanks, Erika. Thanks, everyone. That was really interesting, really, really helpful. I hope everyone else on the call found it as interesting as I did, even though I do this stuff all day, every day. I always find it interesting and helpful to listen to other people. So there are no questions in the chat, but I'm just going to really quickly ask if there's anyone on the chat that's got any particular questions or anything that they would like to ask or ask clarification on. No. Okay, we'll take that stunned silence as a good thing. So just to close, I want to say thank you so much to everyone that's joined the call, everyone that's joined to listen. Thank you to Erika, Bharath, Andrew, Jyothi and Liz for talking us through and sharing your knowledge and your experience. It's always fantastic. So like I said at the beginning of the webinar, this is our 4th webinar of the Safer series. We've got one more session to go, which is next week, next Wednesday, 4 till 5, same time, same link. You are all more than welcome to join. After this session, we'll be sending around a video of this session, along with links to all of the other sessions that we've done. If you haven't joined the NHS Futures site yet, do go and have a look. It's really good, loads of useful resources there. You can find all the videos of the webinars and other webinars that we've run. So finally, thank you so much for joining. I hope you found it interesting. Thank you again to our panel members and Erika for chairing so well. And thank you for everyone that joined. I hope you all have a nice evening and we will see you hopefully next week.